whenever you still have your uterus, what you do is that you place your thumb on this side of the uterus, and then you place your other fingers here like that to evaluate if the child is going to have engagement. So you move at this level here, at the level of the pubic symphysis here, to evaluate if there is engagement. If the child head move, it means that there is no engagement. If the child head move, it means that there is engagement. That's the first pelvic grip. Is it clear? Now the second pelvic grip, now you place now yourself at the top of the patient. Look at the feet of the patient, then place your hand as such. Is it clear? Then you palpate, such as to see if the head is flexed. Is it clear? When you palpate to see if the head is flexed, and if there is flexion, it means that the head has already descended and it's already at the level of the flexion. Is it clear? So those are the 4 Leopold maneuver. The first is this, which is the frontal grip. The second is the lateral grip. The third is the first pelvic grip, or also called the pelvic grip. And then the fourth is the second pelvic grip. Is it clear? So those are the different elements of the Leopold maneuver. During your Leopold maneuver now, you can now conclude on if the child has a longitudinal lie. Longitudinal lie means that the fetal spine is going to be in the same orientation as the mother's spine. Then you can also have the transverse line, meaning that the fetal spine is having a right angle with the maternal spine. It is a right angle with the maternal spine. And then you can also have an oblique lie. Is it clear? You can have an oblique lie where the fetal spine, this is the maternal spine, this is the fetal spine. This fetal spine has a fetal spine is going to have an acute angle or an oblique angle. Is it clear? With the maternal spine, it has an acute angle or an oblique angle with the maternal spine. So this is the acute angle, and now this is the oblique angle here. Is it clear? With the maternal spine. Is it clear? So those are the different things that you visualize with the lie. Now after the lie, now we have the position. Now for the position, we need to use a reference point in order to define position. It with respect to the reference point of the presenting part. Is it clear? Is with respect to the reference point of the presentation or the presenting part. Is it clear? So what is defined? What is position? Position is the relation. The position is defined as the relation of the reference point of the presenting part as compared to the maternal pubic symphysis. Is it clear? Pubic symphysis. That is the definition of position. It is the reference point of the presentation, the presenting part, as the relation of the reference point of the presenting part as compared to the maternal pubic symphysis. So what do we mean by that? So when you say that it is that, it means that what is actually the reference point of the presenting part? If you have a cephalic presentation, and then in that cephalic presentation, it is brow presentation, the reference point is going to be called the frontal. It means that it's the frontal bone which is the reference point when you have a brow presentation. Is it clear? Now, when you have a mental or chin presentation, when you have a chin or face, preferably face presentation, we first have the brow presentation, you have the face presentation. When you have the face presentation, it is the chin or the mentum which is the reference point. So you use the mentum to be their reference point for you to speak about the posterior and anterior relationship with the maternal pubic symphysis. And now when you have a vertex presentation, you use the occiput. Use the occiput to be your reference point. Similarly, if you have a breech, when you have a breech, you use the sacrum to be your reference point. So let us take an example. We take an example first with the normal, which is the vertex presentation. So when you have a vertex presentation, the vertex can be occipito-anterior or occipito-posterior. It can be occipito-anterior, is it clear? Or it can be occipito-posterior. Is it clear? Now, in the case of occipito-anterior is when the occiput is closest to the maternal pubic symphysis. Meaning that what? Let's say that this is the pelvic outlet of the mother. If the occiput of the child is here, and here is the pubic symphysis, when the occiput of the child is here, it is called the occipito anterior. Is it clear? So when it is closest to the maternal pubic symphysis, the occiput is here, then the child is coming out with his nose here, with his mouth here, like that. This is called occipital anterior. Is it clear? But now, when the occiput is instead this other way, is it clear, and then the nose is turned, then instead the eyes here, is it clear, it is called instead occipital posterior position. Occipital posterior position. Is it clear? And that occipital posterior, usually the best position is the occipital anterior position, actually with less risk of perineal tear, but occipital posterior position is actually with more risk of perineal tear. Is it clear? So those are the different elements. So we have already visualized fetal geometry. We have visualized inside the fetal geometry, we have visualized the width, and we have the different presentation, the lie, and then the position. Now we continue now with the fetal well-being. Thank you.